Hi, everyone. As we're talking about engagement and clinical interviewing in this week and the upcoming weeks, I wanted to provide a few tips and clinical insights to applying these skills in practice settings. When we're completing an interview with a client, this can look different depending on the setting you're in. Sometimes you might be completing something that seems more so like an intake assessment. For example, why are you here for mental health services today? Other times, this might look like you're interviewing for reasons associated with risk. Maybe you're working for Children's Services and you're at a home doing a safety assessment relating to allegations that the kids haven't been going to school and disclosed exposure to domestic violence. So you might be talking to kids and parents about these reports. Sometimes you might be assessing and interviewing for readiness to change and engage in a substance abuse treatment. And all of these scenarios will prompt different questions, different skills, different styles of engagement, and might happen at various times throughout the process. I wanted to share a few tips with me as someone who's learned and made many mistakes in my career. The first thing is make sure you're giving anticipatory guidance to your client, whether you're doing the interview or whatever you're doing in that session that day. We can all imagine that when a social worker is talking to you, it may be and likely is because things aren't going great in a certain aspect of their lives. I often see with newer social workers that they build extensive rapport with a client. And while rapport is incredibly important, spending 20 to 30 minutes talking about the weather or favorite foods or something like that before introducing your role and why you're there and what you're going to be talking about can be kind of confusing. So think if this client is perhaps anxious about this interaction because the CPS worker is coming over and I don't know what they're going to say, and now we've been talking about the weather for 32 minutes, imagine what could be going on in their head for the conversation, waiting for the other shoe to drop, or just wondering, are they trying to trick me? Is the social worker testing me? Are they assessing me right now? Did that answer sound okay? We really want to put ourselves in their shoes and understand what we are there for. If we think about it, an easy way to fix this would be to explain what you're doing. So something like, I'm going to be asking you some questions about the kids not going to school and some other things that they mentioned. Before I do that, I really just want to get to know a little bit about you. So tell me about yourself. Another thing would be to avoid jargon. We love our acronyms, we love our abbreviations and words to describe our processes, but often these things are unknown to our clients. And if you think back to maybe a job or your placement, there were probably terms or phrases that people use that had been working there that you had to learn yourself. We want to treat people with respect, but also be sensitive that we all have different understandings. If you go to the doctor and they give you a diagnosis, but they don't tell you what that means and instead give you this big long word, that's not trauma informed. You could leave there thinking, am I dying? Do I have a headache or a hangnail? It can mean a lot of different things. So we want to really be trauma informed and explain what this means, especially if we're going to use some phrases that they haven't been familiar with before. In my work, we do something in basic interviews called a stress and resiliency screen. And these questions are comprised of risk factors relating to kids' health. But I see a lot of newer workers saying things like, I'm going to do a stress and resiliency screen with you. What does that mean if you've never heard that before without further explanation? What these questions are in this stress and resiliency screen are things like exposure to domestic violence, mental health concerns, drug use, etc. And you might not know that by just using this label of stress and resiliency screen. So instead, I encourage newer workers to say things like, I'm going to do a screen with you, something we call a stress and resiliency screen. These questions are comprised of things that impact kids' health, things like domestic violence, substance abuse. Do you mind if we talk about that right now? And that really paints a different picture by giving them that anticipatory guidance of what they're talking about. So instead of being concerned that a social worker is talking to them, we explain the purpose for our visit. Just by changing that wording and providing that guidance makes a world of difference. It shows that we're meeting people where they're at. It shows that we're engaging with people as equals, and it really changes it than having this professional versus client dynamic. We also have to be mindful of education and literacy levels. Sometimes it's not applicable to use a written form for everybody. I'll tattle on myself about a client that I previously worked with years ago in crisis mental health. This client was deaf and used sign language. my agency at first was unable to get an interpreter, so I opted to start writing some questions down and have him respond. And his responses were very minimal, and that's how I obtained information about his mental health and did some lethality screening. Later that day, once I did speak with an interpreter, he explained to me that some people in the deaf community write at about a third grade level. And so that showed me that there were some significant gaps in information and communication that could have been missed, especially with something as important as lethality screening. So the best thing to do from the get with that client was to wait for an interpreter before doing any type of interview or assessment to understand what he best meant and what he needed. In further discussion about anticipatory guidance and engagement, it's important that we talk about informed consent, confidentiality, and mandated reporting. And this discussion is a skill that we'll practice during our role plays, and you'll likely modify your spiel a little bit as you move forward in your work. Not only is discussing these topics trauma-informed, but it can and should be discussed in a way that's non-threatening, but also informing people of their rights. Many times you'll hear, before we start talking today, I want you to know that I'm a mandated reporter and everything we talk about is confidential. While that shares a little bit of information, it's inaccurate for a couple reasons. One, not everything is always truly confidential, and there are a couple different reasons for that. Think about if we discuss their case with our supervisor. Is that confidential then? Probably not. Even though it's okay we do that, we really want to be honest about our intentions. So if I were to start a session with a client, I may say something like, before we start talking today, there's a few things I want you to know. First, I want to talk with you about your informed consent. Insert rights of client through agency here. Next, I want you to know, while we're talking today, this will be confidential, but there are a few exceptions to that. I am a mandated reporter, so any report or suspicion you may mention of child or elder abuse, thoughts of hurting yourself or others, knowledge of animal abuse is something that I am mandated to report. If that were to happen, I would be disclosing some of your information, which could include some of what we're talking today, and I'll make sure to answer any questions you have about that, and I'll tell you that before I do so. Another reason I could potentially not confirm that this is confidential is if I were to get subpoenaed for your records by a court, or if I'm discussing this with my supervisor for supervision purposes to help me learn, or if I'm looking for advice. Depending on the setting you're in, you might also discuss the use of keeping records. You may say, you see me taking notes right now? You can ask to read them at any time. It's to help me remember. Especially for those working in mental health and the medical field as social workers. Recently, we've had a big change in medical records since the 21st Century Cures Act, and this allows for medical records to be released immediately to clients and patients to their MyChart or whatever account they might be using. And this has been something that has changed a lot of people's jobs, mine as well, because if there is a concern going in a medical record for danger or abuse, the person or persons involved with this family can review that. So if we think about this in potentially a domestic violence situation, an abuser might be able to read their victim's medical records and why they were at the hospital or a doctor's office or the facility for whatever reason. Many times what I'll do is I'll tell people that your medical record can be viewed by you at any time, but I also want you to be mindful that if you've shared your password or if someone else has access to your phone or computer, other people might be able to read that too. If you feel like something you're going to tell me could put you in danger, please tell me so I can make this note sensitive and so I can ensure your privacy as best as I can. I apologize for not discussing more theory during this video. We'll definitely cover more of this quite a bit during this semester, but I do find that the introduction of our role and some housekeeping parts of engagement tend to be the most anxiety provoking for people, so hopefully this helps.